My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and today's call is, Learn and Share conference call is on the ketogenic diet. It's not just for kids anymore. And we're very happy to have with us as our guest speaker, Jennifer Fillenworth, who's a clinical dietitian at Mercy Health Howenstein Neurosciences. So welcome, Jennifer. Thanks for joining us.
Yeah, thanks for having me today.
Great. So can you start by introducing yourself and sharing a bit about your clinical interests and your experience with this particular topic?
Well, I've been with Mercy Health now for going on 3.5, 4 years. For a majority of the time I was working actually in psychiatric medicine. I've also worked in our ALS clinic, our Parkinson's clinic, HIV, and then I recently picked up the ketogenic diet clinic here about 1.5 years ago. So up until I would say about August, I was doing a lot of different things full-time as far as that goes, and then recently I dropped down to only doing the ketogenic diet, so that is my full focus now.
Great, great. So before we get into any details about the diet, and we're going to get into some significant details, but before we do that, can you give kind of a broad overview of the ketogenic diet and its primary variants that are used?
So there's many forms of the ketogenic diet. I tend to think of the classic ketogenic diet as a 4-to-1 or a 3-to-1 ratio. And what that means is that's our grams of fat compared to our grams of protein plus carbohydrates. So in the classic ketogenic diet, the one you're typically seeing used on of children, patients that have tube feeds, and then we also use that for status epilepticus. That is going to be more so where you're weighing out food. It's more strict. You're paying attention to calories. And then moving into more of the modified Atkins diet, which we do a lot of here in our clinic, that's going to be a 2-to-1 or a 1-to-1 ratio. So they're a lot more lenient as far as the amount of calories you can have per day. The carbohydrates jump up to about 6% of your daily intake per day as opposed to 2% in the classic. And then we also have the low glycemic index treatment, and that's about 50 to 60 grams of net carb per day. And what that means is the low glycemic foods are ranked from 0 to 100. So any of your foods that are 50 or less, those foods they don't elevate our blood glucose as much. So those are things that are encouraged. They have more fiber in them. Things like dark leafy greens, apples, those types of foods would be okay. And then we also have the MCT oil, and that one we don't work a lot with here. The only instances we use that are in our status epilepticus patients, where we will add that to our tube feeds if we need to. But that diet is even more lenient with carbohydrates, usually between 40 to 60 grams. But the reason why you can do that with MCT oil is because it produces ketones a lot faster than a long-chain fatty acid would, which are typically found in butter, heavy cream, meats, things of that sort. So those are some of the different types. I could talk all day about all the guidelines for each of them, but that's a brief little overview of those.
And can you just talk about just briefly the basics behind why the ketogenic diet is thought to work? What are at least the proposed or theorized mechanisms behind why it is effective for some people?
So the biggest mechanism that all these diets have in common are it's mimicking a starvation state. And there's a lot of different theories and a lot of mechanisms of why they think it's really working. There's a lot of different hormones that increase in the brain. The anti-inflammatory processes typically go down. So there's so many of these mechanisms that it's hard to pinpoint, is it just one thing that's making it work, or is it all these different things? Because if you look at somebody, say, that's doing the low glycemic index treatment, they are probably not producing ketones because the carbohydrates are low enough. But yeah, on studies where there's patients doing this for epilepsy, they're still seeing some of the same beneficial results. So I think that's what makes it so hard to pinpoint, is it could be so many different things, but we know that it's that mimicking the starvation state is what's helping control seizures.
Okay. Okay. So can you talk a little bit about the history of the ketogenic diet from its use over 2,000 years ago, or the use of fasting to its current resurgence in the past 25 years or so?
Yeah, so it was actually first mentioned in the Bible where it said, there was somebody that was foaming at the mouth, and they said treat with no food, nothing, just letting them fast essentially to heal. And that concept has been around for thousands of years. And then finally in the 1920s, using that whole fasting starvation state, that's when the ketogenic diet was really born. In between that time, I would say in the 1990s, it really started to fade away again because there were so many anti-epileptic medications being introduced. And typically in medicine, if you have a medication that you can take as opposed to a lifestyle change, unfortunately everybody's going to swing and go that way and say, let's just take the medication. So we saw it decline quite a bit, but yet with all those anti-epileptic medications, there wasn't a real change in people that were having all this relief from their seizures. They were still intractable. They were still having a lot of complications. So I would say right around the late 1998 to 1999, that's when you started to see it come back a little bit. That's when more clinics popped up around the country using the ketogenic diet and how it started to come back today, and I think it's bigger than it ever has been, so I'm excited to see where that goes.
Right. So why has the diet until recently been used almost exclusively in young children, and why is that starting to change?
So right around that 1998, 1999 period was when there was actually adults that were starting to be put on this diet because somebody just, finally caved and said, we're using this in pediatrics, why can't we do this in adults too? And by doing that, they were getting similar data that they were in the pediatric population. So I would say right around the year 2000, it started to make a comeback and be used in adults. And I think another thing with that, too, is with children, there's a lot of factors. They have caretakers, there's parents there, a lot of people to control a lot of that aspect. And with adults, we're on our own. We're more likely to cheat on our diet, and it's harder for us to follow when we're in different social situations. So I think that more adults willing to compromise those things or plan a little bit more, I think that's why we're seeing so many adults interested now.
Right, and there's also more availability now with your program at Mercy Health, and I believe University of Michigan has one day a week or one day a month. I can't remember exactly, but they have a program that they do for adults as well. There didn't used to be that availability in Michigan. Is that correct?
Yes, and I believe it's Denise Potter with U of M that's doing that.
Yeah, great. Okay, so under what circumstances do patients and families typically consider trying the ketogenic diet? And are there particular types of epilepsy for which the diet is more or less likely to be successful?
So I would say patients and families start to look at doing the ketogenic diet when they've failed a couple of their anti-epileptic medications. Some people are just saying they want to try to wean off medications, and that's why they want to try it. Some people are looking for a more natural control. So there's a lot of different reasons why they consider it. As far as types of epilepsy that it's more successful, I actually had to look this up, and there are a couple promising studies specifically on GLUT1 deficiency and then pyruvate dehydrogenase deficiency. So those are a couple where I think there's 2 or 3 case studies that were promising on those types of epilepsy.
Okay, great. So once someone decides to try the diet, what are the first steps to get started?
So I can talk a little bit about our clinic and how we handle that. We typically bring everybody in for initiation, education type of visit. So they will meet with myself and Dr. Tanner at that visit. And what we do is we lay out all the ground rules basically for starting on the ketogenic diet that they would need to know about. Before that visit too, when we get the referral, we send them with lab slips, so they'll get a complete metabolic panel, lipid panel, organic urine acids, and that's to test for any sort of metabolic deficiency that they maybe have never discovered. And in an adult, that's quite rare that we would see anything come back abnormal there. So those are just some of the first steps, getting that complete lab work done to make sure there's no contraindications, bringing them in for education. And a lot of it, too, is really basic nutrition education at that point, too, and just explaining, do you know what counts as protein? Do you know what carbohydrates are? Do you know how to read a nutrition label? So things like that really set you up for success, because if you come in and we're going to start you on a ketogenic diet and you've never read a label and you don't know what a net carbohydrate is, that's where it gets tricky. So we want to make sure that everybody's well educated and that they're set up for success at that first visit.
Great. So once you've discussed that, what are the various factors that go into the choice between doing the full ketogenic diet, the modified Atkins diet, the low glycemic index diet, or another variant?
So for any of our tube feeding patients, they typically get a classic ketogenic diet. We use either Keto V or Keto Cal formulas for that. And then what we can do is if they're on a 4-to-1 ratio and for whatever reason they're not tolerating that, or we need to go a little bit lower, we can always modify that too by adding in products and playing with that ratio a little bit. Most of our adults that are on an oral diet are going to be started on a modified Atkins diet, typically a 1-to-1 ratio. And I think we only have 1 or 2 patients that are doing the low glycemic index diet. And I would say most of the patients are very comfortable with the modified Atkins diet, and they find that once they've been on it for about 2 weeks and they have some recipes they like, they have snack ideas, that they're really comfortable doing that, so there's no need to change it.
Okay, so it's largely the choice between modified Atkins diet and low glycemic index diet is largely a matter of preference?
I would say so, because most of our patients, they want to just do the modified Atkins diet. They also really like the ketone production from it too. We have had one patient that had a really hard time producing ketones on it, and that's where we go and look at food logs and we say, are your ratios correct? Is there something else that's not going on? And usually from the food logs that we gather from the patients, we're able to see right there, you know, you're not hitting your ratios, you're not consuming enough fat, you had too many hidden carbohydrates here. So I would say most people are very successful on the modified Atkins diet.
Okay. And are you more likely to recommend starting with an easier diet and then working up to the full ketogenic diet if it's not effective enough? Or does that ever happen where someone is started on a 1-to-1 ratio and it's just not working? Would you then step it up to a 2-to-1 ratio or even to a 3-to-1? Or how does that work in terms of the process of maybe shifting the diet if it's not working?
We've been very lucky in the fact that we haven't had that experience where we've had somebody on a 1-to-1 ratio and it's just not working. I would say more so we've had people on a 1-to-1 ratio where it's not working in the sense where it's too difficult for them. So they have actually gone to a low glycemic index diet, and that has been better for them. We've also had tube feeding patients that have come from, you know, being on a 4-to-1 ratio when they were at the pediatric age, and they were lost to follow-up because they turned 18 and their clinic was no longer following them. And by that time, they need a major adjustment because they need more calories. We need to look at different supplements. And I would say most of the tube feeders end up on about a 3-to-1 ratio after all said and done once they're adults.
Okay. So what's the rationale for fasting versus not fasting to start the diet? Is there any consensus on that? And does that only apply to the ketogenic diet, or does that apply to the modified Atkins diet as well?
So typically in pediatrics, when you do the classic ketogenic diet is where they would do a fast, and they would be inpatient for this as well. Another instance where we would use fasting is when we have patients in our ICU that are in super refractory status epilepticus, and we are going to initiate ketogenic tube feeds. We will keep them in the fasted state for 24 hours, and during that period, they're off their propofol, because we cannot have propofol in combination with the ketogenic tube feeds. And I would say that's really our only times that we fast. With the modified Atkins and low glycemic index, we never fast our patients.
Okay. Once the diet is, or once you've decided to start the diet, how often does the patient meet with a dietitian and neurologist?
So once we bring them in for the diet initiation, they have full access to email me all the time, which I tell them if you are in the grocery store, you are confused about something, you don't understand something, email me right away. That comes right to my phone. And then after that, we typically send them out with labs that they'll have drawn a month after beginning the diet, and then they'll come back and see us in 3 months. And then at that 3-month follow-up, then they'll typically come back for another 3 months after that, unless they're doing absolutely great, their labs are doing really well, there's no need to see us, then we'll schedule it for an additional 6 months out. So it's typically every 3 months for the first year.
Mm-hmm. Okay. So can you talk about a little more about the rules and ratios upon which the success of each diet depends? You've already mentioned the ratios, but maybe go into a little more detail.
Yeah. So I'll talk a little bit more about the modified Atkins diet that we're doing here. So for a 1-to-1 ratio, we do 69% of our calories are from fat, 26% are from protein, and 5% are from net carbohydrates. So when I say those net carbohydrates, what I mean is we are taking our total amount of carbohydrates and we're subtracting the fiber right out of that. Since we don't turn fiber into glucose, we don't do anything with it, we don't need to count it in that ratio. For more of a classic ketogenic diet, they're going to be up to about 90% total fat and about 2% of their net carbohydrate and 8% protein. So there is a lot of success in those ratios. If I'll look at food journals a lot, and I noticed for one meal, you know, their ratio was really far out where their fat was only at 1, where their carbs were at 5. So it was like a 1-to-5 ratio and a complete inverse. And they said, well, you know, it kicked me out of ketosis. And that's because whatever this mechanism is, if you're not following your ratios, it could kick you out of ketosis instantly.
And what's the effect of that with the ketogenic diet or the modified Atkins diet? If you are in ketosis and then you have a slip up and you're then out of it, does that just basically render the diet ineffective as soon as that happens, or does that put you at increased risk for seizures? How does that work?
So that is an instance where that's a common question is, you know, can I have a cheat day on this diet? And what we know about the mechanisms behind it, they're very instant. So that is something where, you know, you go to a birthday party and you have a piece of cake. That's immediately going to change your environment in your body, and that could cause a seizure instantly. So that's why we tell people that it's not really cheating, because we look at this as a form of medication. You don't want to ever just skip your medication just because. So that's why it's important to be compliant with the diet and look at it in the sense that it is a medication and you should continue doing it for all those benefits.
Mm-hmm. So obviously having a piece of cake is one thing, but how much flexibility is there in terms of the 3 different diets? Are there days where you can with some diets where you can have a little bit more carbs or a few more carbs and be okay, and then with other diets, if you have any carbs, it's going to throw you out of ketosis and you'll be at high risk for seizure. I guess what's the relative flexibility with the different diets?
I would say the most flexible with the diets are going to be your low glycemic index and your MCT oil diet, just because you have a higher range of carbohydrates allowed for those. Same with our modified Atkins diet patients too, because some days they'll say, I only used 8 grams of my carbs, but maybe they're prescribed 25 per day, so the next day they hit their prescribed amount. So I think as long as they're staying within that prescribed total, that's okay. Once you start to push beyond that, you're changing your ratios a lot. So, for instance, for a meal, say you want to have, you're used to having a turkey sandwich rolled up with some cheese, maybe some mayonnaise, and then all of a sudden you're going to throw a giant tortilla around it or maybe some bread. That right there is going to completely change your ratio, and at that point it's no longer ketogenic. Does that make sense?
Yeah, okay.
Okay.
Now, you're having to track a lot of, you mentioned having a food journal. How easy is it to track carbs and fiber and protein and fats from existing food labels? Is all of the information that people need on food labels, or is there information that you wish was on food labels that sometimes isn't?
That's a great question. It is definitely not all on food labels, because a lot of the foods, too, that we're prescribing are, obviously there's things like berries, there's our dark leafy greens, broccoli, cauliflower, all those things. They don't have nutrition labels on them.
Right.
So what we've done is we've actually created sheets for them that have all the fruits and all the vegetables that they could possibly get their hands on, and we list out serving sizes for a quarter cup and a half a cup, and on there it has their total net carb. So we show them how much total carb is in there, how much fiber, and then we subtract those out to get their net carb. So I always tell people, take those to the grocery store with you, put them on your refrigerator, and once they get used to kind of measuring out those amounts, they get very good at knowing exactly what their ketogenic meal should look like in their portion sizes. Usually a good rule of thumb is any of their oils, heavy cream, butter, any of their fats, those are going to be measured in a tablespoon, which is equal to 14 grams of fat. So it's some of those educational pieces that we do together when they meet with us, and we have all those things written down for them, and it's a matter of just putting it into practice until they're very comfortable doing it on their own. And it takes a little bit if you're not used to measuring out every little thing you're eating. But I would say when they do that and they write down their meals, all of a sudden they're creating all these recipes for themselves too, which is really helpful for them to create those grab-and-go meals and snacks and things like that.
Right. So have you, we'll talk more specifically about menu plans, but in general, do people tend to have more success if they plan the entire week out when they go shopping and have every meal planned, or are there people who are creative and able to think on the fly enough to be able to kind of do improvise a little bit in terms of meal planning, or does it really have to be very regimented and planned out ahead?
I would say I have both types of those patients. I think they're very good at what they do in both senses. I think some people are just able to adapt more quickly and be able to pick those things up where they kind of can just eyeball something and say, hey, I know this is my fat here. I know I have at least 3 servings of that. I know that I'm under my carb here, whereas I'll have the other group of patients that say, let me break out my recipe book. What do I have written down here? What do I need to get at this meal? So I think it depends on what kind of person you are, really. If you're a planner or if you're more free-spirited and you're going to do kind of whatever you're going to do. I would say both have been very successful, though.
Okay. So can you give me a typical menu plan for a day? Maybe perhaps one for modified Atkins diet and one for the ketogenic diet, just so we can kind of compare what a typical menu might look like for the different diets.
Yeah, so for breakfast, I would say a lot of times there's eggs involved. Patients will either do, scrambled with heavy cream, or they'll do butter. They'll typically have some sort of breakfast meat, avocado, things like that. So that would be more modified Atkins. Classic ketogenic, you're going to be more controlled in your protein, so that egg portion is going to be smaller, and you're going to have a lot of fat added to that. And I know that's typically where things get a little complicated with classic ketogenic, because just that mouthfeel of so much fat can be very hard to do. So that's where it's a little more lenient in your modified Atkins, where you're getting more eggs with a little less fat. You can have some breakfast meat. There's avocado in there for more fat. But then your avocado is also going to have a little bit more carb in it too. For lunch, there are actually a couple different brands of ketogenic or low-carb wraps out there that I would say fit very well for the modified Atkins diet. So a patient could use one of those wraps with meat, cheese, lettuce, and mayonnaise, where for a classic ketogenic diet, you wouldn't be using those wraps because those are about 6 to 7 grams of net carb, and that would be too high for a classic ketogenic diet. So at the classic ketogenic diet, you're going to be using just your meat, cheese, you're going to have mayonnaise on it. You're probably going to have some other sources of fat as well with that. And then dinner, you could do chicken thighs, you could do broccoli, olive oil, and then for classic keto, again, your portion of chicken is going to be quite small, and your portion of broccoli is going to be smaller, but you might have more of like heavy cream sauce on that. You're going to have more butter, olive oil. So for classic keto, your fat is just taking up a really large portion of everything you're eating, and your portions for protein and your carbohydrate are significantly decreased.
So it is what's the difference in terms of the ketogenic diet and modified Atkins diet as far as having to weigh foods out and having to finish every last piece of food on your plate and that type of thing? Does that differ for the two diets?
Yeah, I would say that does differ. So classic ketogenic, like I said, I don't do too much with that. I don't have access to gram scales or anything like that, but that's really where you're weighing things out, and you need to be very specific about it and making sure that the plate is clean and you're getting all those fat calories, whereas modified Atkins, it's more lenient in the sense if you don't finish your entire meal, you can always have a ketogenic snack later. So we do have patients that say, they made this big dinner and they only ate half of it, and they went back later and had a snack. That's okay. I would say modified Atkins too, they're still measuring things out to an extent, but again, it's not as strict where they have a gram scale where they're doing everything. They're more so measuring out their fat in tablespoons and checking to make sure their carbs are inside their goals for the day.
So you've mentioned some commonly used ingredients. What are some other go-to ingredients that are really helpful for either diet?
I would say as far as keeping a little pantry, a variety of different oils are good. I like olive oil, avocado oil. You can get MCT oil. A lot of our patients actually get that over just Amazon.com. Having things like butter, heavy cream, nuts and seeds are also good, avocados. So just those basic fat sources. And I think another big thing, too, is when you think about snacks in America and what we typically go for, a lot of it is granola bars or crackers or maybe flavored yogurts. So that's another mindset that changes too, is what kind of ketogenic snacks can I have on hand and ready to go?
Right. So just another question that I just thought about. If someone is a vegetarian, is it hard to be on the modified Atkins diet?
We have had a couple patients come to us that have tried it, and I would say if you are a vegetarian that wants to try some form of ketogenic diet, I would more so recommend MCT or low glycemic index there, because it is difficult to do with the modified Atkins diet to a point where patients have just said, I just started eating meat because it was too difficult for me and I was eating the same types of things and I was having a really hard time keeping to my carbohydrate limit. So that's where I would just say more so let's try low glycemic index or let's try MCT at that point.
Right. And are I'm not sure about this, but are beans and lentils and soy products, are those fairly high in carbohydrates?
I would say they're moderate because they have a pretty high fiber content. Okay. Yeah, but those, it's difficult though, because if you're on your modified Atkins diet, you're going to be looking at less than 30 grams of carb per day. And, in order to get the amount of protein you need, you're going to be consuming more carbohydrates in the servings that you would need to get your protein from those things.
So what are some hidden sources of carbohydrates that patients and families might need to be aware of that they might not think of as sources?
I would say the biggest shock to everyone is probably just salad dressings in the grocery store. I always tell people to look at those. Just the other day, I browsed Meijer and look at salad dressings. I looked at a label, and they have some out there that are low fat or fat free, and you're like, how do they make Thousand Island or Ranch fat free? So you look at the label, and there's 3 times the amount of sugar in there, and I just think that so many of those packaged foods have a lot of sugar in them, and that's why the label reading is so important with all those things. If they're looking for any type of like pizza sauce or tomato sauce, that's going to be another aspect where tomatoes are going to be a little bit higher in carb and they're going to add a lot of sugar to it. So you can make your own sauces at home. I always encourage people do that. And then another thing that people are always surprised about too is actually milk and yogurt, because those are going to have the natural lactose in it, which is a form of carbohydrate. And I think that's always a shock to hear that people say, oh, I'm used to drinking 2 or 3 glasses of milk per day.
Do cheeses have as much carbohydrates as milk, or no?
They don't, but we have had patients where, so the hard cheese can typically, they don't usually report carb on there, but there can be trace amounts to the point where I had a patient that was eating hard cheese at every single meal, and they couldn't figure out why they weren't producing ketones. And when I looked at their food log, I said, this is a problem right here where you're consuming 2 to 3 ounces at every single meal and snack, and that is likely what's kicking you out. So there are always hidden carbs in places where you wouldn't expect them to be.
And even things like, for people on the full ketogenic diet, there are things in toothpaste and oil, lotions and things like that you never think of, but that can even add carbs, right? Yeah.
And that's even, I know in our ICU too, as far as the patients in status, even just mouth swabs, things like that would have carbohydrates that are hidden in them that you wouldn't think about.
Okay. Are there any ingredients that aren't typically available in an average supermarket? Not
usually. The only thing that people order, I would say offline a lot, is the MCT oil. And I don't have anybody that's specifically on the MCT oil diet, but there's just a couple people that will add it into, maybe they're making some sort of drink or some sort of shake, and they'll just add in a tablespoon there. So nobody's using it to a point where they would need a lot of it. So I would say it's more of just one of those ingredients where they have on hand if they need it.
Sure. Does the diet end up being more or less expensive than a typical diet, or roughly the same?
So I actually had to research this one too. I would say grocery bill-wise, it looks like everybody was spending just a little bit more on the ketogenic diet, but they were also spending way less money on fast food and takeout, less money on, as far as adults go, going out to the bar. Because a lot of people before they went on the diet were saying they were going out to the bar 2-3 times a week and putting up a pretty hefty tab. And now that they weren't doing those things anymore, really it evened out where even they were spending less total on the ketogenic diet because they weren't doing those things as often.
Right, right. How does alcohol fit into the equation? Because some alcohols, wines and beers, can have a lot of carbs, and you know, most people with epilepsy do not drink extensively, or if they do, it's only in moderation. How does that, is there any specific counseling you provide on alcohol?
Yes, we get that question a lot. We do have a lot of patients that don't drink, which I think is great. But at the same time, those ones that do want to enjoy a cocktail, we typically have them, you know, one drink, which would be 5 ounces of a drier red or a white wine. An ounce of any type of hard liquor would be fine, as long as it is with a carbohydrate-free mixer. And then there are some beers out there that are very, very light on carbohydrate. It would be the things that are like Miller 64, all those types too. I think there's only about 2 grams of carbohydrate in those. So we typically tell people, you know, one drink, be careful, don't overdo it.
Right, right. All right, so let's talk about the various reasons why the diet might be discontinued. Probably the 3 most common reasons for the diet to be discontinued are that the patient can't stick to it, sort of tolerability, or dangerous or intolerable side effects or complications occur, or the diet just doesn't work in terms of seizure control. So let's start with tolerability. Because adults are used to a diet with few restrictions, and the average American diet is also heavy on carbs and on convenience foods like fast foods and processed and prepackaged meals, it can be quite an adjustment to switch to a restrictive diet that requires careful planning and prep time and creativity on the part of the person preparing meals. So what are some of the major pitfalls that make it challenging to stick to the diet and may eventually lead to discontinuation?
The major pitfalls, I would say definitely, we are in America. We love carbohydrates. They're everywhere. They're hidden in everything. I think it's just really, you need the support. You need the resources. You want to feel supported by friends and family to be able to stick to it. And, you know, being able to tolerate it, I would say that is the biggest dropout that we have. And if you look at any studies that try to measure adults on the ketogenic diet, just they don't want to stick with it anymore. They're tired of it. They don't want to continue eating as much fat as they usually are. They don't want to keep, you know, planning out meals. So that is a big problem that we deal with, and I think we try to provide the support as best as we can and the resources for them to succeed. So that would definitely be a big part of discontinuation, and that's probably the number one reason we see is people just don't want to do it anymore.
Right, right. So on the flip side, what characteristics of the patient and family tend to be most predictive of successful maintenance of the diet?
I think you always know if the patient's going to be successful when you walk into a room and the family is really engaged in what you're saying, the patient's engaged, they're excited about it. Usually we have families that will do it with the patient, which I think is great because it's another support system. We had a patient come in recently that said their friends had a big party and they made a bunch of ketogenic snacks, and I think it's having all those support systems that really make you successful and having the engagement that makes you successful.
Okay, and we'll talk a little bit more about this later, so just a brief response to this, but is it safe for people to do a modified Atkins diet or even ketogenic diet if they don't have epilepsy and they're just doing it as a supportive thing to support their family?
I would say most of our families that are doing it with the patient typically do more of a low glycemic index because they will add in some things here and there, so they're not following the strict 1-to-1 ratio, but I would say on average they're probably doing less than 80 grams of carb per day. Okay.
All right. So is someone who is a picky eater before starting the diet, is that person going to have much of a chance for success? And do you ever recommend that someone shouldn't even try the diet if you learn up in that initial interview or that initial consultation that they are an extremely picky eater?
So this happens to us a lot too. It depends on the situation really and what type of picky eater they are. Because we have some patients that live in AFC homes, and they say, well, you know, they like hot dogs, hamburgers, eggs, and that's about it. And we say, well, okay, those are all great things. Can we take away the bun and they'd be okay? And they're like, yeah, sure, that's fine. And we say, okay, well, now how can we just add in a couple fat sources and we're good to go? And then they'll eat that every single day, and they're okay with it. So that's great with us. And then on the other end of the spectrum, as far as picky eating goes, we've had people come in that are interested in the diet, and we start doing a little bit of education, and they say, well, I'm not willing to give up my cookies. I'm not willing to give up my Mountain Dew. I have cereal 3 times a day, and I don't want to give that up either. And at that point, you just kind of say, well, I don't think this is going to work if you don't want to make any changes there. So it really depends, but I think being a picky eater can be either good or bad as far as the ketogenic diet goes.
So what are some of the common side effects and that people experience on either diet, and then some of the more dangerous side effects or complications that can occur? And which of these side effects tend to be manageable, and which of them usually lead to discontinuation?
I would say, so I'll start with some of the more dangerous ones. That would be if you're looking more so at a classic ketogenic diet or a higher ratio, you always run the risk of possibly acidosis or overketosis. And at that point, you would typically either lower your ratio or you could treat with bicarb. That's what we would do in the ICU to control the acidosis. That's quite rare. And then as far as more common side effects and things that we would see in modified Atkins would be things like constipation. We always tell people to drink lots of water, make sure they're getting their fiber from like dark leafy greens and things that they can that way. They can add flax seeds to things. We typically see a little bit of elevation in the lipid panel when they first start, which tends to taper off the longer that they're on the diet, actually. So I don't know if it's just an adjustment period with the body where you're switching from using glucose as your main fuel source to using ketone bodies, but we do see, not in everybody, but I would say about half have a little bit of elevation in their cholesterol that will go down as time goes on. So those are some of the more common things that we see.
Okay. Outside of seizure control, what are some of the long-term health effects of being on the diet for a significant amount of time, both positive and negative? And is anything done during the diet to try and prevent the negative effects? And lastly, are any of the negative effects, let's say if you've been on for several years, are any of the negative effects reversible, like they would go away if you stop the diet?
I think anything, if you're on it for long enough, you could reverse side effects. So say if you were on it for a little bit of time and we absolutely could not get cholesterol levels to decrease for whatever reason, then going off the diet and back onto more of a I don't want to say typical American diet because I think that's the problem with a lot of cholesterol, but say we wean down to more of a low glycemic index or a Mediterranean type diet, I think that would correct itself. As far as some of the proposed things of the future of the ketogenic diet to study are, you know, is it safe in the long term? We really don't have an answer for that because we don't have a population that's been on the diet for an extensive amount of time because it's so new. So that's what I would say as far as, you know, we don't know if it's completely safe for a very long time, but at the same time, our patients have been on it for a couple of years now, and we aren't seeing any negative side effects from that.
Mm-hmm. Okay. So what is the average duration of the diet? What's the longest you've ever seen, and what's the average, I guess?
So I have been in our clinic for a year and a half now, and we've had people on the diet for that entire time. And like I said, they don't have any signs of having any adverse effects to that. So as long as they want to continue it and as long as we continue to monitor labs, we're okay with that because our patients are also supplementing with multivitamins, calcium, vitamin D. And at 5 years on a ketogenic diet, you would typically recommend that they would get a bone scan too because your diet is going to be lower in calcium and we're supplementing. So that's just another precaution of what we would screen as well.
Okay. So a recent study in the Lancet showed that both high-fat diets and low-carb diets were associated with lower risk of mortality than low-fat diets and high-carb diets. Can you talk briefly about how opinions are starting to shift towards the idea that higher fat and lower carb diets might actually be healthier for people in general?
Yeah, so I mean, in this country, we eat more carbohydrates and processed foods, I think, than anywhere in the world. And if you go anywhere else in the world and you sit down for a meal, a lot of times you're having a protein, you're having some sort of vegetable, and maybe a little bit of starch, maybe like a little bit of pasta, a little bit of rice, but it's nothing excessive. And I think that we've taken it to the point now where even some of our normal dietary guidelines, we're supposed to have 6+ servings of grains a day. And when I think about that now, I think that's pretty high. That would mean I'm having, you know, oatmeal for breakfast with fruit and then a sandwich at lunch and then maybe a big bowl of pasta later to round out my carbs for the day. So I think we're moving in the right direction. I don't like to bash carbohydrates either because I think there's very good ones out there, obviously, with fruits, vegetables, some types of whole grains out there. But I think it's interesting to see how this is coming into play and how finally we're saying, you know, it's not fat that's killing us, it's all the sugar that's in every single thing that we're eating. Right.
Okay, so let's talk about outcomes with the diet. What have studies shown in terms of seizure-related outcomes for each of the diets?
So this is another statistic that it's kind of all over the place. Okay. I would say based on studies that we've all pulled, usually 50% have some sort of seizure reduction, and that 50% they're seeing usually 50% of their seizures decline. So that's in about 50% of the population. And then out of those, anywhere from 14 to 30% can go seizure-free. So those are just some of the numbers behind that. I think a lot more needs to be done to pull really good statistics behind that. I think there was one study on GLUT1 deficiency in particular where 75% of the people that went on the ketogenic diet were responders. So that's another really high statistic there. So just as time goes on, I think we'll be able to get more evidence behind that, but I would say at least 50% of people are responders to it.
Okay, and is that for just the ketogenic diet, or is that for the modified Atkins diet as well? Have there been fewer studies for a modified Atkins diet than ketogenic diet? And I guess how is the evidence base for that versus ketogenic?
There are a little bit less for modified Atkins, but as far as early statistics that they pull from that, it's pretty similar to what the classic ketogenic diet statistics are.
Okay.
Yeah.
And do the percentages vary according to various epilepsy-related or demographic factors, or do we just not have really that level of detail in terms of the data?
Yeah, I don't think we have that level of detail yet. That would be interesting to see, though.
Okay. And what about other outcomes? Have studies shown any changes in mood or cognitive function or physical symptoms or overall quality of life as a result of the diet?
We have actually, a lot of our patients will come back to us, and not only is it helping with seizures, but they say that, their cognition is improved. A couple patients that are in AFC homes that may have had a traumatic brain injury history, all of a sudden their behaviors have improved. And some of those things, it's kind of amazing to me that it's not only seizure control, but, these people are thinking more clearly, their behaviors aren't as erratic. And when I was at the Global Symposium in Canada, that was one of the topics from Harvard, is they wanted to use this diet in the psychiatric population and see if it helped with cognition and mood symptoms.
Okay, so some promising signs that might be an added benefit, and obviously more research needs to be done. So
right, and I think it's about finding those populations too where you can do the research and people are going to be really willing to do it and stick with it, and I think that's the biggest barrier to getting more of this data behind these things.
So while on the diet, do most patients stay on anti-seizure medications, or are some able to reduce their medication while they're on the diet?
So this is one that I discussed with Dr. Tanner a little bit, and most of our patients usually stay on one form of an anti-seizure medication. We have had some that have decreased. As far as other medications, though, we've had a lot of our patients no longer need blood pressure medications, metformin, and we've had a lot of patients whose A1Cs improved dramatically because we do have a decent amount of our population that also is type 2 diabetic, so we've seen a big change in the diet there as well.
Okay. If the diet is successful, at what point do neurologists consider weaning the patient off the diet? And then what's the rough likelihood of seizures returning after doing that?
So we talked about this one a little bit earlier where we haven't gotten to the point where we've had to wean anyone off. And Dr. Tanner said she would probably keep people on it for as long as they wanted to be on it, as long as we were doing routine labs and checkups and things like that. I would say for classic ketogenic, though, I've seen some people weaned at 2 to 3 years. I don't have statistics of seizures returning after that. I do know that those patients typically go more to a low glycemic index diet as well versus returning to a typical American diet. So those are just some things that I know about that.
Okay. So often when patients and families contact us, they ask if simply shifting their regular diet towards one that has more fats and fewer carbs will be effective at reducing their seizures. Are the diets that we've discussed kind of all or nothing diets, or can simply incorporating elements of the diet have some benefit, specifically in terms of seizure control?
Well, I think, so there's all the varieties of ketogenic diets that we talked about. I think there's a lot of good options out there. As far as you had somebody that said, I want to try to incorporate more fat into my diet, and they were adding heavy cream and butter to everything, but they were keeping maybe their carbs the same. That's one instance where, that just wouldn't work. We don't have data on that. You're just eating a ton more fat, but you're also eating the carbohydrates. It's not going to mimic the starvation state in any sense. So I think there is a very fine-tuned science behind each one of these diets where it's best to follow those recommendations for the diet that you're on.
Okay. Is there enough information on the internet or in books that someone could theoretically do one of these diets on their own, either low glycemic index or modified Atkins, so they wouldn't need to have a dietitian? I know that's obviously not recommended. I'm just saying if someone decided to do that, is there a possibility that could work?
Right, and so my concerns with that is we do so much with blood work in the beginning to say, is this going to work or is it contraindicated in your case specifically? And then there's so much we do with supplementation. And like I said, we haven't had anybody at that 5-year point yet on the diet, but, if we do, we're going to have to start incorporating bone scans into that as well. So I don't typically recommend that people just go and do it. If anything, I think low glycemic index would be the easiest to do on your own. But I've also had people, in a lot of our team, actually, in our clinic, does the modified Atkins diet. So these are all people that are surrounded by us, and they can just ask us questions anytime they need, whereas they say they go on the internet and kind of look things up, and they say, I get completely confused with all the information out there. So I think it is best to have a medical team behind you that can guide you through it.
Right. Okay. I've also had several people mention going on special diets that aren't designed specifically for epilepsy in the hopes that it will help, like gluten-free diets or paleo diets or cleanses or those types of things that are some level of fad diet. So other than specific cases where the person has seizures due to complications from celiac disease, in which case a gluten-free diet would be recommended, is there any rationale for trying such diets, and are any of them possibly dangerous for people with epilepsy?
I would say as far as specialty diets go, what I take into consideration would be true food allergies. Is somebody having a reaction to something? A lot of times, too, with irritable bowel syndrome, that could be a million different things that's causing that. So I think everybody is so individualized, and it's best to figure out what works for you and what doesn't. And that can be a really long process. It could be elimination diets. It could be trialing different things. So that's a really big answer, and it's very different for everybody. As far as cleanses go, I've never been a fan of that. I think that's a little wild to me that people do that. So I wouldn't recommend that, but obviously gluten-free for celiac. A lot of people actually do have some gluten sensitivities too, where they notice if they cut those things out, they feel a lot better. So I would say diet is so individualized, and that's as far as being a dietitian and practicing. I know that there's a lot of blanket standards out there and a lot of things in the media that they think everybody should try, but I want to know what works best for somebody on an individual basis.
Right. So recommendation, if you're considering trying any kind of special diet, you should talk with your neurologist, with your primary care physician, and
right, absolutely,
to a dietitian as well.
Right, and I think there's a diet out there now based on people's blood types, which I can't understand yet. So there's always some sort of new diet that's out there, and I'm trying to keep up with all of them too.
Right. Okay, so outside of the ketogenic diet and its variants, what are some common sense eating habits that are likely to improve overall health and that may help with seizure control?
I tend to push people a lot towards a Mediterranean-style diet, and what that means is it is higher in your unsaturated fatty acids, so in your nuts and seeds, your olive oils, avocados. I think incorporating more of those fats into our diet is a great thing. I think moving away from processed foods is a great thing. I always try to take people, especially in the summertime in Michigan, to farmers markets, and they're always amazed. They're like, wow, look at all this great food here. It's like, this is exactly what food should be, though. It should be fresh. It should be made from people around us. It shouldn't be coming out of a Pop-Tart box in a grocery store. I think just shifting more towards that whole food sense is going to do great things for people. And I always encourage people to, buy less processed foods and to stick to more of their, meats, vegetables, fruits, and things like that.
Okay, and so mentioned the internet, obviously, which can be a double-edged sword, can be some great information out there, but also some very misleading information. What are some resources that you would recommend, books, websites, organizations, that type of thing, that can help families who are trying the ketogenic diet or modified Atkins diet?
So my favorite book, which I actually have in front of me right now, is called The Ketogenic and Modified Atkins Diets by Eric Kossoff. He is kind of our modern-day ketogenic diet pioneer. He puts out pretty much every study you've seen over the past 10 to 15 years is his study. So that is a really great book. And then as far as websites go, for glycemic index information, it's just glycemicindex.com. And that is one where it's really hard to find information, but that website does a good job. The charliefoundation.org is a big one for all types of the ketogenic diet, and you can actually go find recipes for any type of diet there too. And then matthewsfriends.org is another website on the ketogenic diet. So those are all really great ones.
Yeah. And what do you think about a few companies focus on making specific foods and drinks that are designed specifically for the ketogenic diet? How do those integrate into someone's diet, and is that something that should be used kind of like the MCT oils are used, in that it's kind of something that can be helpful as a supplement or to add to the diet, or is it something that it can be, people can rely on those products exclusively?
Yeah, and I think Mary Susan is here. She's with Keto V, and they actually produce really great products. You can get breads, you can get pizza, and those are really nice too, because we have a lot of patients where they'll come home and say, I worked a long day, I just want to heat up something real quick, and I think they have a really great line of products for that. And they also have we use the ketogenic tube feeding, but those supplements you can also drink as well, and they come in chocolate and vanilla. And I mean, I've tried them. I think they're really good. So it's a good supplement to use too. A lot of patients that may be doing more physical activity that, maybe they're used to drinking like an Ensure, a Boost, or something like that, they can easily switch and do a Keto V product instead. Cool.
Okay.
Yeah.
Let's go ahead and open it up for questions. Okay, so before we have any questions, does anyone from the audience who's tried the ketogenic diet or modified Atkins diet or low glycemic index diet want to share any experiences or suggestions? Do we have anyone on the phone who's used any of these diets?
We use the modified Atkins diet for my daughter, and actually she has refractory epilepsy and has been on 8 different medications, surgery, and we actually were seizure-free for 7 months, and it was the longest she's ever been on. And then I have a question, though, in part of my comment,
Sure.
And that's for whatever reason, the diet just stopped working, and I'm pretty confident it had nothing to do with noncompliance. If someone wants to return to the diet, and she was on it when she was about 15 to maybe 14 to 16 years old, 17 years old, for a little over 2 years, if someone returns to it now when they're 21 as adult, do you have any experience? I know you probably personally don't, Jennifer, but have you heard, what is the success rate when you retry the diet?
So we have had a couple of patients that were on it as children and then they wanted to get back on it later. They have been successful at just returning to the ratio that they were on. When did you say that the diet stopped working for her?
Well, it took us about, I want to say maybe 4 months to really get to the point where she was seizure-free. And then she was seizure-free for 7 months, and then we actually stayed on it again for maybe another 6 months before we just decided to wean it off because it wasn't effective anymore. Okay.
And how old was she?
She was probably, I want to say at the time, maybe like, we did it from when she was like 14 to 16 years old, and now she's 21.
Okay. So, because I'm sitting here with Susan, and we both kind of looked at each other, and hormones can be a big factor around that time frame of why it would be difficult to keep her in ketosis. And at her age now, I wouldn't see a problem where if she started again, I'm sure she would be able to get back into ketosis and be successful on it again at the same ratio that she was on.
Okay. Thank you.
Okay, great. Any other, before we get to more questions, anyone else want to share any comments or experiences with the diet?
Hi, Russ, and everybody. This is Yovo. Hi. Everyone, just so you know, I'm a 49-year-old male that developed epilepsy later in life and adult onset, and I've been on the modified Atkins for the past, now approaching 3 years for folks that are considering doing this, and met with tremendous success early on, and still am on it and still doing quite well. And what I mean by that is seizure rates had decreased by, let's say, in the neighborhood of about 70%. Not eliminated, but reduced tremendously, and that's been quite effective. So folks, at least for me, so folks that are considering it, trying it out, it's in order to reduce seizures. In my case, it did actually significantly reduce seizures, and that was with even coming completely off of seizure medications. While it's not zero, me and my medical team are still working on how to actually become seizure-free at this stage. However, it's once you get into it, it actually is a lot easier than you think. And at this point, I can't imagine going back to what your speaker had said to be a typical American diet. Everything's too sweet. Should we say that? I mean, even tomatoes taste like strawberries to me. So what
it's
really kind of funny about it.
What are some of the biggest tips you would give people, or things that have helped you the most?
Well, what worked best for me to be effective is to focus more on the net carbs more than anything else. Keeping in mind with dietitians about the ratios that are involved with particular diets, I've been pretty close to sticking to the modified Atkins, and alcohol as well has not been an option whatsoever. Right. Even though I sure miss my beers, but you can't. If you want to be successful in reducing or possibly eliminating seizures, it's just the path you got to take. And I'd encourage folks doing that. But when I focused strictly on keeping the net carbs down to the levels prescribed, that was extremely effective. And the hidden carbs, as you guys brought up, you really got to learn to read the labels as best as possible. That was critical. It's surprising, more than surprising, where the hidden carbs are found. Right. And as well as the last element, what you do have to keep track of course, this type of diet is not nutritionally complete, and so the various supplements are necessary to keep track of exactly as far as vitamins and things go. And the bonus upon all that, as you guys had already reflected, blood pressure issues, which I had before, are all gone. And a wonderful side effect of being an adult male is I happen to have lost weight, too. That was really nice, in the neighborhood of 70 pounds, to be precise. So that was a nice
big thing we see. Yeah, all our patients are very happy with the weight loss that they have as well.
That was an unexpected bonus, and definitely not part of.
Yes.
It was all very much focused on eliminating and reducing seizures, and that was very successful. So, if anybody else please, I hope give it a try. And for the lady just talk about her daughter going back on it, if they're right about probably the hormones, give it a try. Hopefully, it'd be successful, and I wish you luck on that. If there's anything else I can help answer, I'd be glad to anytime, guys. Thank you.
Great. Well, thanks so much for sharing. That's really helpful. All right, let's open it up for questions. Does anyone have any questions about any of the diets we've discussed?
I have one specific question. I also was diagnosed with adult onset epilepsy. And my question is, I've also been diagnosed with borderline cholesterol issues. So I'm not supposed to eat anything high fat of any type. So how do I solve that problem?
So I will say that we've had a couple patients that have come in for initial labs, and their cholesterol is fairly high as well. We actually have a couple people that have had cardiovascular disease, and we usually discuss it with their team as well, and we'll talk to cardiology. But it hasn't been a problem as far as the diet goes, because like I said, we typically see a little bit of elevation in the beginning, and then they tend to decline after that. So I would recommend that you get a consult in labs, absolutely. I don't think it's a contraindication for everybody.
Okay, thank you.
Great.
You're welcome.
Other questions?
Jennifer, do you recommend any sweeteners if you do have somebody that just needs to add it to something?
So we do talk a lot about sweeteners when people come in. A lot of people will ask about sugar-free syrup, and that's something that has sugar alcohol in it that we do not recommend, but they can do something like a stevia or a little bit of Splenda. We don't encourage they use it a lot, but it is in some of the recipes if you're craving something that's sweeter. A lot of our patients will make something called a fat bomb, which is essentially a really high-fat, delicious, like fudgy tasting item, and they'll use just a little bit of stevia for that.
Thank you.
Other questions?
Yes, this is Diane Edgerton. My son is a 30-year-old adult now. He takes seizure medicine, but he wears what they call a neural pace device. Would this diet have any bearing on, if he started this diet, would he have any issues because of that with the device? You wouldn't think so, right?
I don't think so. We don't have anybody with that right now. That would be a great question for Dr. Tanner. I wish he were here. But I don't see that there would be any contraindications for that.
I can't imagine what they would be, but certainly something you can certainly just, it seems like it shouldn't be a barrier to at least getting evaluated or talking about this.
Right.
Right. Okay, and the other person who started the question?
I do have a note here from Susan that Dr. Tanner does have experience with that. So if you wanted to give our clinic a call to schedule an appointment, we could do that as well.
Oh, thank you very much. And what was that clinic? What was that number again, dear?
It is 616-685-5050.
Okay, thank you very much.
You're welcome.
Someone else had started to ask a question?
Yeah, thank you. I know, Jennifer, you said you don't have any outcome data on this, but I just wondered in your experience if you had any information on the effectiveness of the diet with like generalized tonic-clonic seizures versus is it effective with simple partial seizures?
So I would say we do have a lot of patients with simple partial, and it has been successful in those patients. I think right now they're just more so studying GLUT1 and pyruvate deficiency because those are very hot topics as far as pediatrics go in seizures, but we haven't really seen any type of our population with one diagnosis that does better than the other. So I think it's worth a shot for everybody that has any type of epilepsy to give it a try.
Okay, thank you.
Jennifer, can I chime in on that one?
Yeah.
This is Mary Susan. I know from my experience with the pediatric population that the nice thing about ketogenic diet is that it works for all seizure types. So unlike medications where X medication may work best for seizure type A but not for seizure type B, the diet tends to work for all seizure types.
Thank you.
Sure.
Okay. Other questions? Okay, while people are thinking, I have a question. At Mercy Health, with your program, have you ever worked with another epilepsy center, like had a patient who sees an epileptologist at, Henry Ford or some other other epilepsy center in the state where you can work remotely? Have you ever tried that? Is that something that you would consider if someone didn't want to necessarily leave their current epileptologist but wanted to have access to your program?
Sure, and we haven't had that happen yet, actually. We've had a couple patients that transferred as far as pediatric goes to our program to transition just as far as adult providers, since there were none over in the West Michigan area. So we have had a lot of patients transition to adult care as far as that goes, but I think it would be a nice idea to work remotely because I've had a couple patients that, they drove up here from Kalamazoo and then say they were admitted at a hospital down there. I've had dietitians from the hospitals reach out to me for guidance on what to do because all of a sudden they have this ketogenic patient there and there's no protocols in place and they don't have anything on hand that they need. So I think that's where hopefully there's a change in the future where we have more providers that are trained in ketogenic therapies. I think there's such a need for it.
Right. Okay, so that's at least a possibility that someone could look into.
Sure.
Yeah.
Mm-hmm.
Okay, great. Other questions? We have just a few more minutes left.
I've got a question.
Yep.
This is Diane. The question I've got is I'm wondering, with a 616 area code, are you out of Grand Rapids?
Yes, we are out of Grand Rapids.
Okay. And I'm assuming that the doctor you work with is this Dr. Tanner that you've mentioned?
Yes. Yep.
Okay, because my question is that my son, he is 23 now, and he's got I think it's retractable epilepsy anyway because he's kind of medicine resistant. The one kind of sort of works. We tried this on our own, and it's really, we really need to get in with a dietitian. And the question I would have, I guess, and that piggybacks with what the commentator was saying, is if I wanted to see my epileptologist, who is epileptologist at Henry Ford, who told me, yeah, go ahead, get in with a dietitian, could I come in with you to get him on this, or do I have to go through your doctor? I guess I'm wondering.
That shouldn't be a problem if you just want to come in and see myself, because the way we've been doing it is no matter what, Dr. Tanner will come in and meet with the patient as well.
Right.
It doesn't say that she has to resume just primary care of everything, but she will come in and meet with you and kind of, because we are a team, and discuss it together.
I understand. And can I ask you just quickly, do you also take Blue Cross Blue Shield as far as insurances?
Yes, we do.
Okay. Thank you.
Okay. Time for probably about one more question, one or two.
Could you just mention, Jennifer, how you spell the name of that product line, Keto V?
Yeah, it's KETOVIE.
Okay, thank you.
Yep.
Hey, Jennifer, I was curious, too, about the labs that you draw. Are there any concerns at all with long-term ketosis on kidneys?
Not that we have seen, and we do get asked about that quite a bit. And, fluid needs do increase with the ketogenic diet. A lot of people are drinking lots of water on it. But when you're in ketosis, too, your kidneys actually start excreting sodium a little bit better than they would on a typical American diet. So you can actually have a little bit more salt, too. And that's something in our tube feeders that we see. We might have to supplement with a little bit of salt in there as well if their sodium drops too low. So your kidneys actually get really, really efficient at excreting things.
Great, good to know. Thank you.
Okay. Time for maybe one more question. Okay. All right. Well, I think we're all set then. So just really want to thank you so much, Jennifer, for such a great call, and we learned a lot, and exciting therapy for people who may not have otherwise considered it as adults, and I know we have a lot of parents on the line too. So there are also pediatric ketogenic diet programs at I think all of the pediatric epilepsy centers in the state. So that's always available as well. So definitely something to consider if medications haven't worked. And so thanks again. And the next, if anyone has any questions about epilepsy in general, just feel free to call our 1-800 number at 1-800-377-6226 or visit our website at epilepsymichigan.org. Okay, so thanks again, Jennifer.
Yeah, thank you.
All right, bye-bye, everyone.